And I'll use this opportunity to say, when I talked about the NK stuff, I said it helps me bring a couple of thoughts together. And the lovely Paul Song, who is that radiation oncologist I worked with in the community, I once went and visited him and noticed that he had a new desk in his office, which was weird. Paul's a very important guy. Sometimes those people need two desks. But I asked him, what's that desk for? And he said, that desk is for Stephen Shiao. And Stephen is a revelation for us and our patients because he really does understand immunotherapy as it relates to the utilization of radiation and focal therapies. And that's important. That field is expanding exponentially. How to give it, when to give it, and where to give it. So with that, I'll bring Dr. Shiao, who's from the Department of Radiation Oncology at Cedars-Sinai, and a great colleague.
Thank you, everyone, and thanks to Omid for introducing me and for inviting me to give this talk. It's always hard to follow such excellent speakers. So I'm going to tell you something a little bit different. Basically, as many of you know, radiation is in a familiar, I should say, cancer treatment. But I think what is not well known has been that we've kind of revolutionized really our understanding, both in terms of how we can deliver radiation in more focused and better ways to limit toxicity, but also the biology of radiation, which is something, my laboratory studies, but I think as radiation oncologists, we're very interested in understanding the immunobiology of how radiation can integrate with some of these amazing kind of new therapies that are coming online over the last couple years. And so here's my disclosures, just so, so basically I'm just going to start by talking about some of our current applications in melanoma. We do have a role as kind of one of the traditional pillars of cancer treatment. But I would say that, we've had a tough history with melanoma in some ways. And one of the reasons is because historically, melanomas have been perceived to be very resistant to radiation. And that's sort of absolutely true. So one of the ways we used to give radiation, and we still do to some extent in some diseases, is to give a little bit of radiation at a time. Like you give it to like a large area and you give a little bit at a time. And the reason we did that was because it's safer to give a little bit at a time so your body can recover from each dose of radiation. And so, but because of the intrinsic biology of melanoma, so as many of you know, they're highly resistant to sort of reactive oxygen species, which is sort of how radiation actually works, is by generating reactive oxygen species that kill tumor cells. Because melanomas are highly resistant to that, they were always resistant to maybe low doses of radiation. And so one of the things that's happened over the last maybe 10 years or so has been a revolution in how we both deliver and plan radiation. So radiation, we are one of the first fields in medicine to actually take advantage of AI. So we were the first to have such advanced computational skills. And the reason we needed that was because we were able to now, we have computers that are connected to our machines that essentially can shape the beams however we want. And so you can see here, I'll give you some examples of very focused radiation. And these, the kind of center parts are very hot, and then the kind of rest of the body is pretty cold. And so we can do everything from multiple brain mets, which you can see there, as well as small different tumors all throughout the body. And so why does this really matter? And the reason why it matters is because one of the things that we've known for a long time in melanoma has been that if you can give a higher dose per day, essentially, you can control the melanomas better. And so and to some extent, you can control individual tumors quite well. And so this precision allows us to deliver the dose in ever increasing doses, safely. And so now it's become less of a question of how much dose do we give in some sense, but more where do we give it and when do we give it? And so where we give, so just to give us a background of where we start, this is where radiation is sort of used right now. Of course, as you know, so we're a local treatment modality in many ways, and that's kind of where we've been historically. And so surgery is the first. So when you get a melanoma, you do surgery. And then, but sometimes the surgery, despite our surgeons' best efforts, and they're all amazing, don't get everything, or there are microscopic disease questions that are left behind. So we sometimes do it to the tumor bed to try and increase our control rates for local disease. And then also, sometimes when there's a lot of nodal disease. So I gave you all these criteria here, but the fact is just, when there's bulky disease in the nodes, radiation can do, even though they take them out, we can do a pretty good job controlling the microscopic disease. And so other common indications, just many of you might know, so radiation still remains, about half our patients are palliative, but we give different kinds of dosing now. So for melanomas, especially, we do lots of different brain or visceral metastases, and so a lot higher. And so, but we often use radiosurgery in that approach. So different from a lot of other diseases that we treat, melanomas we treat specially because we give them different kinds of doses, which are shorter but bigger in each dose. And then another one that we've kind of moved into, and this is something that gets into this therapy, sort of, can we do definitive treatment? And so because we can give such precise dosing, for some melanomas, you can do radiation alone, but obviously surgery remains the primary one. These are for patients who really couldn't undergo surgery. But really we're trying to think about, so we've been doing radiation for melanomas for a long time, and we have a lot of options to do that. So I was, when Dr. Hamid invited me to give some thoughts about where we're going with radiation in melanoma space, I kind of came across or thought about kind of two ideas. And then one is this idea, which sort of takes advantage of this concept of being able to control disease locally. And it's the idea of oligometastatic disease. So oligometastatic disease is something that we've kind of known about, and it's sort of a thing that's been batted around, but it's really important for radiation oncologists, because one of the things that we can do now is we can kind of target anywhere in the body, right? And so our question has been, well, where do we target, or what do we target? And so we do have some physical limits, right? So sometimes, as many of you know, metastases and some of the pictures we've seen today are like, just too much, right? And so we can't do that. But there's a really narrow window sort of in between that space where patients have limited amounts of disease, something we call oligometastatic disease. And that's something we think of as, for lack of a better thing, we just counted them. We think of them as like 5 or less metastases. The number is very fluid, and I think it depends on sort of where they are and kind of things like that. But for these purposes, we think of a limited number, somewhere between like 5 to 10. And so because we're able to deliver doses that can control this disease, we wanted to ask questions about, okay, well, so does that even matter, right? And so we have randomized trials in which this is one where we've done multiple kinds of disease. So these are patients from lots of different disease sites, many of whom have failed their multiple lines of treatment. So you've seen patients undergo many, many lines of treatment, but yet their treatment, or they might be partially working, in which case, but they still have a few sites that are growing. And so we took patients that had about 5 of these different sites, and we randomized them to either treating everything or just doing palliative, meaning, if there was something uncomfortable or it was causing pain. And so you could still get a little bit of radiation, but you wouldn't kind of go all out. So we essentially treating metastases that aren't symptomatic to try and ablate them. And in fact, what was really interesting about this, obviously there was breast, colorectal, lung, but there's some other, and of that other, a few of these patients were melanoma. You can see that, in fact, what surprised us all was that, in fact, there was an improvement in survival. And so not only did it improve progression-free survival, which we would have expected because we're treating disease that is progressing, but it also improved overall survival. And so, we think that, in many ways, being aggressive in this space, is a way for us to kind of think about patients in a new light, that you do have metastatic disease as a patient, but it's possible that we can control it. And in some situations here, you can see you could control it for quite some time. And so So when we think about it that way, then we also think about, so when can we apply this? So of course, there are lots of different situations of oligometastatic disease. There's sort of the upfront oligometastatic disease, so patients who are initially diagnosed with metastatic melanoma, who have a limited number of metastases. So obviously, my colleagues in oncology, they have they have first dibs on that. But the question will be, what if there are things that don't respond or things that are not responding completely? Is that a time in which we can do radiation? And then something we've been doing with Dr. Hamid has been, what if you're controlling disease on your current regimen very well? But as the question that Dr. Sullivan brought up, well, what's the next step? We don't know what the next step is, but sometimes maybe the next step is you should stay on what's working and we should take care of some of the bits that aren't working, right? And we can do that now. And so we asked, could radiation, in some ways be a treatment line? And so we've looked at this and we've done a retrospective review. And so this admittedly, so retrospective data is sort of our weakest kind of data, right? So it's data where we've kind of looked back at patients and we treated them a certain way, but they're not randomized. So, obviously this is you have to take this with a grain of salt. But when you look back at patients who have oligometastatic disease or oligoprogressive disease, and you see them and you treat them at that time, you can see that if you follow them out, many patients have long-term control. So in the oligoprogressive state, even though it's obviously not as good as when you're upfront, treating them all, the oligoprogressive patients still do really well in the sense that, almost 60% of them 3 years later are still kind of going strong. So, this could be a strategy in which we think about that. And so, so when we think about sort of what are some of the next things that we do, this is like clinically applicable now in the sense that we refer to oligometastatic states. And so we look for these patients. And so when we're in tumor board or when we have patients, sometimes we remind our medical oncology colleagues, if we have patients who have a meaningful number of metastases that are doing well on their current treatment, but we can treat them, we need to find them and be aggressive about it. So even though patients are not symptomatic or things are otherwise going pretty well, the earlier we can do it, not only are they smaller, so they're safer for radiation and for radiosurgery, but also, we can control that for the long term. So finally, I think this is the one that everybody's kind of most interested in. This is something that's near and dear to my heart. I'm an immunologist by training. And my lab studies immunology. So we do a lot of immunotherapy. And so, this has been something that we've been kind of thinking about, for a long time. And we've been trying to figure out. And part of it is because from this paper, which is one of the earliest papers that we've seen this from one of our colleagues at Memorial, Michael Postau. And basically, this is just a single case report. But what's really intriguing about it, and this is like proof of concept, as Dr. Hamid would say, is that this proof of principle is that essentially this is a patient who had been on ipilimumab and was then subsequently failed. So you can see there's lots of different sites of disease here. There's like in the spleen and in the lung. But what we did is that this patient then went on to receive a specific kind of dose of radiation. So this high dose radiation just to the lung lesion. So none of the other lesions. And this patient that was no longer responding to ipilimumab suddenly re-responded. So this question of resistance or how we develop it sometimes might be able to be abrogated by radiations. And this is the proof of concept for that. And so, we've been looking at it. So here's some work from our lab, but also from other places where we've looked at not only mouse models where we've seen that, when you treat with radiation, that radiation is sort of an immune event. So we know that radiation actually integrates well with immunity. And also you can see here that melanomas from patients, you can see that when they're immunosuppressed, they don't do very well, even with radiation. And so that kind of gave us a hint that radiation itself is an immune event. And so one of the things that we've been looking at very hard is what is the nature of the immune event that happens post-radiation? And so we know a lot now. And so some of this is from our own work, but some of it is from many of my hardworking colleagues that showed that radiation actually releases specific kinds of danger signals. And so that's what you see in this first part, in which you see a lot of proteins from dying cells getting released. And those things actually attract immune cells. And then the second part that I think is underappreciated is that radiation also causes antigen presentation. So like the question about whether you have immune cells that respond to your tumor, radiation has the ability to kill cells and they get eaten, almost like an in situ vaccine. And so we see that immune cells come up, and especially T cells that are very important for targeting tumors, and that this leads to another response. And then in many situations, you can clear the tumor with radiation, but part of it underlies its efficacy, we believe, is its ability to stimulate a de novo immune response. And so one of the things about the potential of radiation is there are two kind of aspects of it, is that perhaps it can make not only bigger immune responses, but it can also make better immune responses. So not only does it augment inflammation, but it also can make maybe new T cells or have your T cells recognize new things. And so then we would like to look at synergy. So of course, we've already talked about local responses. And so I won't belabor the oligometastases point, but it also integrates well with immunotherapy. So as many of you know, sometimes you have 90% of all your disease addressed by immunotherapy, but there's 10% of it left. And those can still be addressed. If you address them by radiation, you can have a dual purpose in the sense that it can control it both locally, but it may also enhance the systemic response. And then some of that is that this distant response question is that if it functions as a vaccine, can we get it to improve immunotherapy responses? And so there have been a number of clinical trials. So over the ensuing years since the discovery of the Postau paper, many of my colleagues, and us included, have participated in the trials where we've been looking at all sorts of different kinds of immune responsive diseases, primarily actually melanoma, which is one of the first index cases. And unfortunately, what you see here is that when we've combined it, in fairness, these are patients who have gone under many layers of treatment. So they've had 3 to 5 different lines of treatment, many of which have failed immunotherapy. We do have a response rate. So some patients do respond, but of course, when you see it, it's kind of disappointing, right? So this summary is like, we thought that there would be like, because we understood the biology so well, that perhaps it would be like gangbusters, right? That we would see huge responses, but it's 10 to 30%, which, you know, in many ways, in fairness, is pretty good for patients who'd gone through so many lines of treatment, and that there's any responders, but obviously is not where we want to be. So kind of a lot of the research going forward in radiation and has been, you know, to understand why has this synergy been so modest, and what can we do to make it better? And so one of the things that we've done is, you know, we've seen that it elicited a good local response, but it has a limited systemic response. So why is this? And so we've taken mice in which we've looked at, these are modeling, so we can look at tumors and then look at T cells that are specific for the tumor. And then you give them radiation and then you look at their blood. And you can see that, in fact, you know, that you can see that these locally, they have an increase in the number of circulating T cells. But then when you look at it in the blood, you can't find them anymore, right? So they're in the tumor that you've treated, but they're not in the blood. And so we've looked at this by something called single cell sequencing. And so we take out these tumors and then both from patients, but also from mice, and we've looked at these. And so this particular example is from mice, because we wanted to be able to look at different time points. So we took these out and we looked to see what happens. And what's interesting, I think, just to see is that you can see that radiation actually stimulates PD-L1, so that's important. So we knew that we need to have that as a backbone for the blockade. But what you also see is that there's these dramatic shifts in the immune population. So I labeled the 2 that we think are the most important, which are T cells, which we've had a lot of talking about, but also another one that is very common in tumors called macrophages. And so macrophages have these very complex immune responses, but one of the ones that we think is most common for them is to suppress immune responses. And so we see that radiation has a dual function in which it not only stimulates T cell responses, but it can also stimulate macrophage responses, which are negative. And this is probably biologically driven in the sense that as we understand the immunobiology, we are exposed to radiation at all times, right? So even right now, we're probably having cells that are irradiated, but you want them to be silent, right? You don't want to have inflammation constantly. So it gets cleared, but part of it is it gets recognized and then suppressed. And so kind of our goal has been to sort of understand, how do we improve this combination of radiation plus backbone of PD-1, and can we get rid of it? And so kind of zip through these, but I think one of the questions has been dosing. And so we think that there's specific kinds of dosing that are better than others. So you can choose to have either big one dose because we have the ability to do that, or you can have smaller little doses. And we think that there's actually a Goldilocks zone for immunotherapy in which you have modestly high doses that are given over a short period of time. And what you can see here is that stimulates T cells better than either than the big single dose, which has been one of our common treatment regimens. And when we look back in patients, you can see that, in fact, not only does that happen in mice, but in patients, you see that they have far more circulating T cells. We don't know if they're specific, but they definitely generate more specific T cells or more T cells when you give the shorter moderate dose or medium dose regimens. And then, of course, there's timing. And so as you see that there's a cadence to it. So unlike any of the other therapies we have, radiation is very timing specific. We know exactly when we give it. And so you know exactly what happens post-radiation. And so this ability for us to understand timing might be very important. So when should we give doses? And so I think a lot of the trials that we've been working on have been doing things like combining radiation and PD-1 on a backbone, but then targeting some of these macrophages later. So you can see that it comes up first, but then you have to wait. And so we have some of these timing questions that are really important and take advantage of our understanding of the immunobiology. And just as a teaser, I mean, I actually had a different picture here, but this one is basically we showed that we now are starting to understand that there's going to be a PD-1 backbone on everything, right? So in melanoma, PD-1 is just de rigueur, right? Everybody's going to get it. That's just the way it is. And but now we need to figure out what is the next step. So we're going to add radiation and PD-1 as a backbone for some of these trials. And then where do we go next? And so I put some examples of some of the open trials, some of which are here, some of which are at other places, including MassGen and MD Anderson, where we're looking at a number of different kinds of immune agents, some of which are things that are designed to enhance the response, and some of which are designed to prevent them from being suppressed. And so we're trying lots of different strategies. And just one of the examples here is in mice, but you can see that here where you can combine some of these drugs with radiation and you get some response, but not much, which is what we've been seeing in patients. And this is even mirrored in mice. But then you can add things that can actually dramatically increase this synergy. And we're hoping to test that now. And so so ultimately, kind of where this goes is that we know that radiation can synergize with checkpoint. We have examples, and we also have some trial data that a small percentage is still here. But we think that you need bigger fractions, so that really matters, and that short courses are really important, and that we think better combinations are important to take advantage of it. So. All right, thank you.